Hi, my name is Colleen McNulty. This is Ashlyn Simmons. We're from William Carey School of Pharmacy.
And we will be doing a professional analysis of the Reconnect studies, section 302, which is the most recent trial. And I'll be going over the basic information of the study.
I'll be covering the results and the statistics at the end of the study.
So for some information about the drug that is going under clinical trials, it is being developed for FSD, which is female sexual dysfunction, and that can be broken down into HSDD, which is hypoactive sexual desire disorder. So the most common concern that women express is lack of desire, and when accompanied by stress, this is HSDD. Up to about 40% of women 18 years or older report having had or currently have a sexual problem, and about 12% of those report distress as well. So now we're going to talk about the drug that's being investigated. It is bremelanotide, and here's the chemical structure, BMT for short, but we're going to call it Vyleesi, which is the brand name. So Vyleesi is an investigational drug that is a melanocortin receptor agonist with high affinity for the type 4 receptor. It is an analog of a naturally occurring peptide, alpha melanocyte stimulating hormone. And so it acts on the physiological and neurobiological components of female sexual function, and that can potentially improve sexual arousal and desire in women with HSDD. And it's being developed for the treatment of HSDD in women that are premenopausal. So for the purpose of the trial, it is to evaluate the safety and efficacy of Vyleesi for the treatment of premenopausal women with or without decreased arousal HSDD. For the design of the study, it is a phase 3 randomized double-blind placebo-controlled trial with an open-label extension phase to evaluate the efficacy and safety of Vyleesi. And there were 714 total participants, and it began in January of 2015 and ended in August of 2016. So for the arms and interventions of the study, there was an experimental group of patients who were going to take Vyleesi subcutaneously, inject themselves with the auto-injector as needed, and they could do it no more than once every 24 hours. And so with the placebo group, they would take a fixed dose of placebo in an auto-injector and subcutaneously inject themselves as well, with no more than one dose for 24 hours. So now for the main inclusion criteria, they wanted healthy premenopausal non-pregnant women, 18 years of age or older, and they needed to be in a current stable relationship of 6 months or longer. They had to be diagnosed with HSDD for about 6 months or longer, and that could be with or without decreased arousal. And they wanted them to have experienced normal sexual function in the past for about 2 years. And they had to be willing to engage in sexual activities for 1 or more times per month. So the patients had to have all of the following at screening. They had to have a female sexual function index total score of 26 or greater, and they had to have a patient health questionnaire total score of less than 10, and on question 9 they had to have a score of 0. The desire domain score had to be 5 or greater, regardless of their total FSFI score, and the distress scale had to be a total score of greater than 18. Now we're going to talk about the primary endpoints. The first one was a change in baseline to the end of the study in the desire domain, and they asked them 2 questions. The first question says, over the past 4 weeks, how often did you feel sexual desire or interest? And the responses ranged from 1 to 5, 1 being never and 5 being always. Question 2 asked patients, over the past 4 weeks, how would you rate your level of sexual desire or interest? And the scores range from 1 being low and 5 being very high. And so they calculated this by adding them all up to both questions, then multiplying that sum by 0.6, and then the scores range from 1.2 to 6. An increase in this score over time shows an improvement in overall sexual desire. For the second primary endpoint, it was a change from baseline to end of study and the score of feeling bothered by low sexual desire, and it was measured by the distress scale. The question that they asked was, how often did you feel bothered by low sexual desire? And they assessed their sexual distress over a 30-day recall period, and they responded on a scale of 0, which is never, to 4, meaning always. And a decrease in this showed a improvement in the level of distress associated with low sexual desire. So the baseline characteristics. The Reconnect study was a combination of 2 clinical trials, and we're going to focus on 302 all the way on the right, and is also the most current trial. So between the experimental and placebo groups, there's little variability. The characteristics of the upper portion of the table displayed an average age of about 39, an average weight of about 78 kilograms, an average height of about 5.5 feet, and an average BMI of 28.6. Now the bottom portion of the table lays out characteristics related to the HSDD diagnosis, including those with decreased arousal and those without decreased arousal, and the amount of time since their HSDD diagnosis. And little variability was found between these groups as well.
Now let's talk about the results of the study and the statistics and what this trial means in clinical practice. But first, I want to cover a few key terms. The MITT population is the modified intention to treat population. All patients who were randomized, used at least 1 dose of double-blind study drug, had at least 1 double-blind follow-up visit. EOS means the end of the study. FSFI is the Female Sexual Function Index on a scale of 1.2 to 6.0, with higher scores indicating desire. The FSDS-DAO is the Female Sexual Distress Scale, desire, arousal, orgasm, 0 to 4, with a higher score indicating higher distress. TEAEs, Treatment Emergent Adverse Events. Table 1 shows the efficacy results for the desire domain score in the MITT population. Before we go into the results, notice that 2 placebo patients did not have either a baseline or end of study measurement, so change from baseline could not be calculated. Therefore, N equals the numbers of patients in the MITT population with an evaluable change in measurement. P-values were obtained from unadjusted Wilcoxon rank sum testing, and they are less than an alpha of 0.05, which indicates that the desire domain results show a statistically significant increase in desire. On a scale of 1 to 6, the mean change from baseline was 0.6, compared to 0 in placebo. Table 2 displays the efficacy results for the distress domain in the MITT population. Again, notice that the sample size was reduced because 2 placebo patients lacked either a baseline or end of study efficacy measurement, resulting in a smaller sample size. The p-value for these results was still below 0.05, indicating a statistically significant decrease in distress associated with sexual activity. The median change from baseline in the Vyleesi group was -1, while the placebo group indicated 0 change from baseline. Bear in mind that this score was rated by a scale of 0 to 4, indicating that women in this sample experienced 25% less distress associated with sexual activity. Significance. In both studies, Vyleesi showed a statistically significant increase in the desire domain score, and a statistically significant decrease in the distress domain score from baseline to the end of study visit compared to placebo. The magnitude of the treatment differences was similar in both studies. Supplementary analyses were performed to interpret clinical meaningfulness of the observed score change from baseline to the end of study in the desire and distress domains. These analyses defined responders for each co-primary efficacy endpoint by anchoring the change from baseline to the end of study with multiple anchor measures. Each anchor analysis considered responders to be those who reported experiencing a meaningful change at their end of study visit. Because 39% of the MITT patients in the Vyleesi group prematurely discontinued the 24-week double-blind treatment compared to 25% of the placebo patients, an exploratory analysis was performed examining the percentages of patients who were able to complete the treatment period and improved from baseline. Figure 1, the analysis of the results. Figure 1 displays the percentages of the MITT patients in the two phase 3 trials who completed the 24-week double-blind treatment period and achieved various levels of increase in the FS-FI desire domain score from baseline. Higher scores indicate increased sexual desire. Figure 2 displays the percentages of the MITT patients in the two clinical trials who completed the 24-week double-blind treatment period and achieved various levels of reduction in the FSDS DAO Q13 score from baseline. Higher scores indicate greater reduction in distress. Table 3 shows the efficacy results for a secondary endpoint. The number of satisfying sexual events in the MITT population. The median change from baseline was 0 in both Vyleesi and placebo patients. However, because this p-value 0.70 is greater than alpha of 0.05, this data is not statistically significant, and we cannot conclude that Vyleesi had no effect on satisfying sexual events. All reported treatment-emergent adverse events for both groups in both studies are shown here. Vyleesi groups are purple and placebo are gray, and the candy-striped colors pertain to study 302. The most common adverse effects in the Vyleesi groups were nausea, 250 events in 627 patients, which is 39.9%. Facial flushing, 128 out of 627 patients, 20.4%. And headache, 69 out of 627 patients, 11%. This chart reflects the perceived severity of the adverse events that we just covered. Again, the Vyleesi groups are shown in purple and the placebo are in gray. Most of them were mild to moderate in severity, but they led to treatment discontinuation or interruption in 18% of women taking Vyleesi, compared to 2.1% in placebo. No serious adverse events leading to discontinuation were reported in study 302's Vyleesi group. In both studies, there were no clinically significant changes in vital signs, laboratory data, electrocardiograms, and no new or unusual safety issues were identified. So now that we've talked about the results of the study and gone over the statistics and the analyses, it's time to talk about the strengths and limitations and how we can apply the study to clinical practice.
So for the strengths of the study, it had an adequate sample size, an adequate p-value, it was safe with alcohol, and it is the first of its kind as an as-needed subcutaneous injection.
And for limitations, unreliable data regarding the satisfying sexual events was shown when p-value was greater than alpha. The adverse events were a little worrisome, knowing that 18% of patients discontinued or interrupted their treatment in the Vyleesi groups. And the other thing that we thought was interesting to consider was we didn't see any studies done on contraceptive use in conjunction with this medication. So how do we apply this to clinical practice? What is the current therapy?
Current therapies are relationship or marital therapy, and they will focus directly on enhancing sexual activity, and they will give them education and assignments to expand the variety and time devoted to sexual activity, as well as hormonal therapy with estrogen and progesterone. And there is one drug, Addie-E, that you take every night for 8 weeks to see the full effects. And they also recommend to reduce daily stress. So how does Vyleesi compare?
Well, Vyleesi is the first only as-needed treatment for premenopausal women with HSDD. In clinical trials, 25% of women with Vyleesi had an increase in their sexual desire score compared to about 10% of women that were treated with Addie-E. And that score is actually coming from the overall Reconnect study, whereas our data mostly came from study section 302. What did the Reconnect study conclude about Vyleesi?
They concluded that Vyleesi is safe and well tolerated, and it could be a potential treatment for women with HSDD to use as needed. And they also said it was safe with alcohol use.
Well, I actually disagree a little bit. Because I know that 18% of the women in the Vyleesi group dropped out or had pauses in their treatment due to the side effects, I feel like it might not be as well tolerated as the company wants us to think. I do agree though that it's convenient and it's nice to be able to use a treatment like that as needed versus having to take it every day. I would definitely like to see a medication similar to this one, but have fewer side effects and higher desire scores. I think further studies also might be needed to address what kind of side effects could be seen in using this with contraceptives.